There are some forms that you're not feeling, and there are some forms that you're feeling, and there are some you start and you don't end. Remove them. Now tell me, what's the importance of documentation as a nurse?
Because if it's not documented, it's not done.
If it was not documented, or if it is not documented, it was not done. And you don't want to spend 12 hours on duty working and yet haven't found time to document. Until it is documented, until I'm able to see and confirm that you have been doing the job and you were doing it at the time you are supposed to do it, you never did it. So let's get it right. Open to your first, there is another form, your second patient. Demographic data for your second patient. Give me the equipment that the patient had.
Right.
The patient had no equipment at all. No BP machine, no glucose, no thermometer, nothing.
No.
Okay. If it happens that the patient do not have any equipment at all, put there no equipment. Leaving that empty space, something can be written on it. It is not just valid enough that you tell me that you did not do something because it is not evidence. You need to tell me whether or not at a particular moment, if you did it, tell me what was the result. And not just going into blank spaces. Because if I see a blank space, you did not do it. You might tell me that the patient do not have any documentation. Yes, I must not be the only person that is going through your files. Somebody might want to go through these files to check what is happening, and then they did not see it. Do you think are you going to send a message to that person? No. It will be considered that you were on duty and you did not fill your forms. So it is completely necessary that if you fill the form and there is somewhere that it does not imply for this patient, indicates that it does not imply, non-applicable to the patient. Are we together? There are so many forms that you have given that I cannot see where or what you were doing. Or you started somewhere and then on another portion you said nothing at all. Now, most often all of you filled your demographic data for the patient, except for this paper that I asked her to go through it because I saw it. For your equipment, what did you have as equipment for that patient, for your patient?
First patient?
Any of them?
Wheelchair, BP apparatus, thermometer, remote, walker, pulse oximeter, air mattress, and suction machine.
Okay, what did you have as equipment for your patient?
Hospital bed, glucometer, blood pressure machine, air mattress, wheelchair, thermometer.
All right. What did you have as equipment?
Blood pressure apparatus, thermometer, pulse oximeter, air mattress, bed, wheelchair, suction machine, commode, and glucometer.
Okay. Now we have our home risk assessment. Initially, I had asked that all of you send your home risk assessment to me when you get to the patient, but the only person who did send was Marianne. None of you sent it. Your home risk assessment, after we have conducted a home risk assessment, which normally or often or always we will be doing it together, I am expecting you to still send me your home risk assessment. And the home risk assessment must be submitted within 24 hours from you. And from me, I must submit it to Hannah within 48 hours. So if I ask you to send me your home risk assessment and you did not send, that simply means I have equally not done my own part of the work. Are we understanding? You must send me your home risk assessment form. I will get the hard copy after we fill it up. I will get the hard copy and can scan it and send it forward to the HMC. And yet I need to see yours. It must be sent to me within the first 24 hours by you, because I only need 24 hours to send it forward. I can see that you all have indicated and right up to signature, and what you still did not realize, I came for some of you 2 times for supervision, and you still did not give me your home risk assessment for me to sign, or you did not see where it indicated I was supposed to sign. Because most of those that I even managed to sign, I signed it myself. You did not give me to sign it when I was checking your document. Is that form signed?
Yes.
Were you the one that gave me to sign?
I only gave you one.
You gave me my form. You gave me your PMI forms. I was the one that signed it.
In the home, the one.
In the home, you did not indicate to me that I needed to sign somewhere. Is your own sign?
Only one.
Where is the other one? Is your own sign? No, ma'am. What's the time now? One, 5 minutes or so.
Yeah, 5 minutes. 1 p.m.
Bring the forms that you have not signed. So I sign it. Don't just give in that hazard matter. Even your name. Whose form is this?
Mine.
Even your name is not on it.
When we were going through the documents with Mom Patricia, she had told us that if we find that there are gaps, we will sign when the gaps are filled.
If you find out that what happened,
There are gaps, we do not sign the day we do the risk assessment. We will sign when the gaps have been completed.
I speak only to
When we were discussing the BMI forms, on the risk assessment, if there were any gaps that we find in the risk assessment, we were told not to sign the document on that day. We will sign it when the family members rectify the gaps we find in the home.
So why did you not sign your own?
Because there were gaps.
Please, reason. Okay? You are out for shadowing. So whether or not there are things in that home that are not available, it is out of your reach to resolve that problem. Are you understanding? It is out of your reach now to resolve the problem. The problem can only be resolved if it is your patient. So if it is your patient and you realize there's something that is lacking, there's something, the patient needs a bed, the patient needs a thermometer, the patient needs a BP machine, you will indicate that these are the requirements or these are the things that are required by the patient. And when you indicate that, then we will submit for them to provide the instruments that are lacking. When they provide the instruments, then we are going to go back for another risk assessment. So this risk assessment you have done, what is the area of concern? Have you read it? When?
Up there, the nature of hazards.
The nature of hazard, and do you see area of concern here?
Yes.
So there is, what is the specimen for?
For any other that is not in the checklist.
Oh, God. Now you have done your full risk assessment, and there are areas of concern in that house. You have clicked on those areas of concern, and when you go down, they said area of concern. It does not mean another area of concern. Okay. Now I will indicate in here in stroke, so in here in writing whatsoever. I am indicating all what I need completely. And when I've indicated all what I need completely, actions needed, what do you want that they should do? You indicate all the actions that is needed to reduce that risk. If there was no BP machine, I need a BP machine. There's no thermometer, I need a thermometer. There's no glucometer, I need a glucometer. And when you've indicated all what you need, of course, to whom it may concern, are you sending this to what? If you're sending it to HMC or you're sending it to PNS, you prepare this form, you say that you're sending it to PNS or to HMC. Okay, now after we have finished this form, we will send it to PNS. PNS provides those documents. We will still go back with a second risk assessment form. We are not going back with the same risk assessment form because this one has been utilized already and has been sent. So we'll go back with a fresh risk assessment form to assess again the risks of that home and making sure that everything was met. If the patient needed a bed, if you needed a table or a chair, has a chair been provided, has all this been provided? Yes, we will sign everything, and if everything is okay, we will come and we'll submit a new risk assessment form indicating approval of all what has been provided and that the home is risk-free. And again, you're on shadowing. That means you have to sign your work because, of course, you only need to indicate what you needed and what is not available, but it does not mean that we'll provide it at that time. It is not your patient. Who has this document? If this document is yours, yes, she signed like a big girl. Which area of concern? What do you want that you should do?
I will elaborate.
You will think about it.
Now,
You realize I already collected your forms, right? You must fill your form correctly. For each space that is given, there is something that needs to be put on that space. I want to see which are your complete areas of concern, and next, what are the actions that you want that they should perform on those places. If you're asking the request from the family, then you should ask the request from the family. Whose home had those things, pots and plates and everything?
Second patient.
Yes.
We patient, it's our obligation.
Yes, all of you had that patient. So in case this is a risk and you wanted those things to be removed, where are you going to be requesting? To whom are you going to be sending? To the family, exactly. You will not be talking to the family. And if you are talking to the family, we are simply going to submit. PNS will call the family and indicate to them this is what we want to be removed from that room. And then they will remove. We will go back the next day or the day before for another risk assessment, and that is it. So it is not all the risk assessment that you are going to do is going to necessitate that we send it to PNS. Some of the risk assessment is just what the family has to do. If you maybe say alcohol inside the family's home, inside the patient's home, are you going to ask PNS to come and take it off? Of course, you'll be sending it to the family and you tell them you don't want alcohol in the home. This is to Aisha. We have to whom you may areas of concern. Okay. Aisha, come on. Okay? My eyes are not good for this right now.
It's mine.
Sorry?
It's mine.
You are the one that is having this Chinese handwriting.
No, this is mine.
Oh, come on. Come on. I think you have glasses. So surely, while you are writing, your glasses are indicating that it's big, right?
I cannot write big. My penmanship is really small.
Okay. Penmanship. Please read your
There is no available fire blanket, fire extinguisher, and smoke detectors at home. No evacuation plan seen at the door and at patient home. Action needed for installation of smoke detectors, fire extinguisher, and fire blanket. Floor evacuation plan should be provided and posed. By who? By family.
Beautiful. Now, did you see that she completed her? And do you see that there is the people concerned to this? For the first patient, for your second patient, where they have no BP machine, who are you going to be requesting for?
The family and PNS.
PNS. Okay. Now, if there's something that has to be done by the family, you indicate what has to be done by the family. If there are the medical instruments, they will be provided by PNS, so you'll be requesting to PNS to supply. Okay? And if PNS has to supply, PNS will call this family cross-check, and then they'll ask somebody in the family to go collect. You signed when I came in, did you show me to sign?
No.
And this is from Aisha. They not equally read area of concern, they not read actions, and then she said to whom? She said to family. What were you saying to the family, Habibi? What were you saying to the family?
Go to the suction apparatus.
The suction apparatus. That is your area of concern. And what actions were you expecting them to do?
They inform to the PNS and the
If they need a suction apparatus, who is to inform? Who is to inform PNS? Who is to inform PNS? You are supposed to give me a report and I send the report to PNS. Okay? Now PNS will call them to confirm. And when he calls them to confirm, then they will go and collect. Do you see the differences? There are things the family will do, there are things that you will do. You are not sending it to the family, you're sending it to PNS. And that is to send it to me, I'll compile them and then I will send them to PNS. I want this field. If you guys had sent me your risk assessment form, I would have access on time and I would have been able to make the adjustments for you not to go to the second place like that. But nobody sent, except Marianne. And this is still you. She signs. What did she sign? She did not care. That was too much work. What was the area of concern? Now, there must not be an area of concern, first off, okay? If the risk assessment for that is done at the patient's home, put the patient in a complete safe environment. Area of concern, you need to write it, there is no area of concern, okay? And then you cross the orders and you come on your sign. That means it's good for you to start shift. Now you start your duty. Because for those that we are not going to see any risks, you are going to start duty immediately. However, for those that we are going to see risks, we are going to go back with you, and then you go back when they provide all what we need. We can now send you back again to the patient after we have conducted another risk assessment for the home. Is that understood? This is your patient. Was there any risk?
No,
Which patient is this?
that was constipation.
Okay, the first patient, her first patient was the one that you went and the family said no.
Yes.
Okay. Now when we go to the nursing assessment and a nursing assessment, nursing reassessment and intervention flow sheet, all right? I see that you are not answering all. This is the 29th, the 3rd, the 4th, the 5th, the 6th, the 7th. That means for your reassessment and intervention, you will need about 3 to complete the month. Is that correct? You need about 3 of these to complete the month.
Yes.
However, I am not seeing who is writing. This is Mary Ann, and she took from the 29 right up to the 7th. I'm filling for each and every day. You will see here. Show me. Yes, from the 27th right up to the 7th. This was well done. From the 23 to the 27. And that too was well done. Here is Prima. 23 to the 27. Why were you not recording rest and sleep? Why? I'm not saying you recording rest and sleep. Was your patient not sleeping?
Because she was doing the day shift, we alternated. There was a patient she was doing day shift, and a patient I was doing the night shift.
And when you are doing day shift, the patient not sleep?
The one that we had, the first patient was not sleeping during the day.
No, that is your argument. I'll take it. Who has this document? Still you? This.
Mine.
Yes.
Yes.
This is the 29th to the 5th. Uninterrupted. Okay. Okay. Now I'm seeing something here. Yes, come.
Tomorrow actually we have interview, right? But I didn't get any reply from Aisha. Did she do anything about tomorrow's interview?
How many candidates are there?
No, still we need to review the series. Only 3 series review. Other series I sent in the group for review. But then I didn't get any reply, and personally I sent message also. I didn't get any reply. I don't know tomorrow I can schedule or not. I don't know.
Check with Madam Christina what she's doing now.
Okay.
If she's free, maybe her to review the series, and then let's just take tomorrow the chances. You can program.
Okay, she's here. Okay.
Yes, she's there. If she can review the series, good. You still make the program, and then tomorrow we can see If it will not be holding, it is easier for them to be prepared and we don't, than not to be prepared and we are prepared.
Okay, fine. Yeah, I'll check. Hello?
I see here your safety. Let me see your safety. Prima and Jisha, let me see the safety that you did. Yes. Under safety, send it to me. Send me back that. I see here you have under safety 4 weeks to use. You have 4 weeks present. You said yes. False calls. What was the false calls for the patient? You did not do it for no day.
That is not true.
Whose document is this?
This one is mine.
Okay, so what happened? And then we go to the 4 weeks levels. Number of 4 weeks medication the individual is taking. Weeks, 4 weeks interventions. Prima, are you with me?
Yes, ma'am.
So what are you going to do there? It is very important that you take complete considerations of the 4 weeks level for that patient. And you should be able to identify and intervene according to how it's supposed to be. Is that okay, Prima?
Yes, ma'am.
And I need this field. Okay. So you see here for Marianne, for the 4 weeks, you see that she has filled everything. Now you cannot be preventing fall, you cannot be ready to open and over if you have not identified the 4 weeks for that patient for that day. Until you have identified, you go for physical assessment and then you assess the conscious level of the patient and all this, and then you don't fill your 4 weeks. This is the only thing you are trying to prevent all through the day. So if you tell me that your patient had a missed fall or the patient had a fall today, and then I check your safety precautions that you have taken for that day, you did not fill. How am I supposed to react to that? And I see that you are not equally putting for mental health, the mental and the emotional status of that patient. What is yours?
I kept calm and cooperative.
Calm and cooperative. Prima? Joshua?
My first patient, I did come in the last 2 days.
Mm-hmm.
Then first 3 days she was agitated and uncooperative.
Okay.
Second one, calm and cooperative.
Hygiene and comfort. Who's on it?
What if my second session?
The second session. Your activity levels here empty.
The patient, or it was night shift, the patient was asleep most of the time.
What time did you take shift?
9 p.m.
And from 9 p.m. the patient is sleeping?
to 9 a.m. when we are handing over. Even when the day shift staff arrives, the patient still asleep.
Then
The patient sleeps from around 8 to until they lift them up for the morning routine.
All right. That's okay. Hygienic nature, because you'll be there, the patient has been already. Okay. Center. Okay. So I want this to be filled to its brim. You should fill every space you have to at all times. So by the end of the month, when you're going, I will give you 3 files of this, which should be able to cover you for the 30 days or the 31 days per that month. And when you're sending your forms to me, you send the complete forms with regards to it. Does that make any sense? All right. For your medication administration forms, I think everyone is filling except for those that are working night during those months. And I already told you how to fill for a medication that is once a week or once a month, or a medication that is twice a week, like that. Was that understood? So we'll send this. This is 20 pages. So when I'm sending, I will send 2 forms so that it will take you for the 30 or 32 days. So that way you don't have to send back any information for any form. You have all the forms you need except for the nursing progress forms, which I will still give you more. And you will try to write directly and stop making a lot of long wordings that does not really entail. You go straight to the point. I'm going to give 3 per shift. That means you'll be needing about 90 for a month. I will give 30 in your files, and I will give the remaining 30 or 40 inside for the extra forms. Is that okay? You struggle to manage that. And if there is still need for me to come or to continue, I will send more. Glucose. Who were those that had a patient with diabetes? You came when they have finished the PMI forms, or you came when they were still doing? You came when Ma'am Patricia has given lectures already, or you attended the lectures? Which of them? You attended the lectures, or you came when the lectures were completed?
Lectures are completed when we start PMI.
Okay. First patient. Your first patient.
Yes.
You have. Just show me from there. I was able to.
Glucose, but no injections.
Yeah, that means the patient is not on insulin sliding scale.
Yes.
Okay. None of you had a patient that was on insulin sliding scale? Okay. Yes, without the insulin sliding scale, you just fill in your results. Okay. So this is what I'm going to try to do to see that your forms are complete. I'll be putting like this, and then I'll put 30, I'll click. And I'll make another 30. So 30 for the month, and I'll give you extra 30, which is going to be 60. So you are going to struggle to see that you use at least 2 of these pages per sheet. I'm not saying you cannot use more. If you need to use more, you go ahead. If your forms are finished before the end of the month, I will provide you with more. You're all taking your reports. To see that. So I have no problem with it. How do you think? What do you think this is? In very short terms. This is your care plan. This is your care plan. And I want you to always handle this care plan with care. It is the first thing you should do in the morning. You should be able to come out with the care plans and your activities for that day. Is that okay?
Yes.
The care plan might not be your usual care plan. It starts with the date, it goes with the problem. That is the problem identified for that day, or the problem for which you were handed over to. The previous nurse tells you the patient had a very, let's say, disturbing night, interrupted sleep. You already have problem number 1, the patient did not sleep well. And then she tells you the blood glucose level is high this morning, 500 milligrams per deciliter, or the BP is very high, 200 on 160 or 140. You already find that there is a problem for that day, or they tell you the patient, this is the third day for the patient to go to the toilet, and you have to prepare for that day. How many problems do you have? The patient did not sleep, blood glucose level is high, BP is high, as well as the patient is constipated. So you have to make your plan according to the problems you have identified. If I tell you, okay, the patient had a good night, the patient had no problem, the BP level is stable, the blood sugar level is stable, okay. For today, maybe activities I am recommending is that she should go for more exercises today. I have given a recommendation, but there's no problem. Now, after my risk assessment for that day, I have to plan. I still have to plan what the activities I want us to carry for that day, because you are either caring for your patient to promote the patient's health, or you are caring for your patient to solve a health issue, or you're caring for your patient to prevent the occurrence of a disease condition, or you are caring for your patient to rehabilitate. Does that make any sense? So because there is no problem, it does not cancel the fact that you can promote. It does not cancel the fact that you can prevent. Neither does it cancel the fact that you can rehabilitate that patient. So if your patient is having no problem for that day and they tell you the patient is completely fine, voila, that is a good thing. That means that we will now move forward from there. It means you will not be thinking about the problem, but now you'll be thinking about promotion. You'll be thinking about preventing of pressure cells. You'll be thinking about rehabilitating. Let's take this person to go for a walk. The patient should engage more in activities. Lifestyle changes. You will now want to take the patient through the different diets that you have seen online, and then you think that will be able to help them with their disease condition, or will be able to help them with their weight loss journey. Do you understand?
Yes.
So you can't tell me that you did not make any care plan for that patient because the patient is not having any problem. Whether the patient is having a problem or not, you as a nurse should know how best to manage the patient. Next, we have the goals. So now that you understand the problem of that day, what are your goals for that day? Now, I always say there's a long-term goal and there's a short-term goal. Now, if we go for the first day, we will be able to get a long-term goal for a patient. Before we arrive that long-term goal, we must have executed 1,000 short-term goals. Are you understanding? Now, if you want to build a house, your goal or your long-term goal is to build your house. But is that where you're going to start from? Are you just going to get one money and the house is standing? Of course, no. You will now start taking short-term goals like saving. You will now start taking short-term goals like providing the equipment and every other thing that you need for the house. You will now start taking short-term goals by identifying who you want to put this project in their hands. And then you will actively be present to see that the house is built from one step to the next, before that long-term goal of a realization of a house will be achieved. Because there are people that build a house after 5 years, after 6 years. Did they start the 6th year? No. They started planning and planning and planning and planning until the time that they wanted to build a house. And this is what I'm saying. If you are looking at my patient is having a high blood pressure, my patient is having high glucose level, my patient is obese, my patient is having mental breakdown, my patient is depressed, and my patient is suffering from COPD, and we are looking for ways to better the patient's life, and we have a long-term goal. I want this patient to have a normal blood glucose level. Yes, the patient will have a normal blood glucose level. Does it mean that it's going to be treated? No. Okay? Because you could take insulin and the blood glucose level will be normal. But again, if the patient eats something that is very sweet, the patient will live from 70, 80, or 110 to 400 within an instant. Okay? So now we'll be talking about maintaining a stable blood glucose level. So if you are going to be maintaining a stable blood glucose level for as long as possible, it's going to take a gradual changes of lifestyle, a gradual changes of you engaging the patient in exercises, a gradual changes of you changing the diet that is made of junk, is made of carbs, to vegetables and fruit. Okay? It's going to be a gradual change of you looking at the patient that loves to take a lot of sweets to a patient, or encouraging the patient to take a lot of water. A patient that was addicted to cigarettes, smoked 30 cigarettes per day, to now maybe smoking 5 cigarettes per day, and you'll be looking at the long-term goal. If the patient today is taking 30, I will keep reducing 1 stick of cigarettes every day, and maybe in 30 days, we will be having no stick of cigarette. Or you say, I will keep reducing 1 stick of cigarette after every 1 day, and in 2 months, the patient should have been able to be satisfied and behave normal without taking any stick of cigarette. Is that understood? Because there is one thing, if you are going to drastically bring the patient from an addiction to living a normal life, you are going to put the patient in another new disease condition, which is withdrawal syndrome. And you don't want to add withdrawal syndrome to the problems that the patient is already having. Because if the patient now has withdrawal syndrome, the patient is going to go worse. It means if they were taking 30, they'll be looking at 40 now, because they want to satisfy the needs of that withdrawal that they are having. Does that make sense? Now, if we leave from the goals for that day, so for the first day that we are going for our check and for everything, our admission report should have our short-term goal, that is the goal for that day, and the long-term goal, where you want to see your patient within, let's say, 3 months, because our services are going to be given for every 3 months. So within 3 months, what is your long-term goal? When you give me your short-term goal for today, I am not expecting you again tomorrow to come and give me a long-term goal. No, I am expecting you to give me consistent short-term goals that are gearing towards the direction of realizing this long-term goal that you gave me for your admission report. Is that okay? All right. Then from the goals, we will go to the duration. Now, what is the duration of whatever you are trying to implement? You got there today, they tell you that the patient did not sleep, and the patient has been agitating, and your goal or your goals is to make the patient sleep for that day, or your goal is to engage the patient in more exercises, so that when they finally sleep in the evening, they will be able to sleep. So your duration here will be how long? 24 hours. Because it is not starting, it's not going to end in your shift, it's going to end in the next shift. And you should be able to ask the next nurse how the patient slept that evening, so you know which direction you should be going the next day. Okay? The care should be continuous. And if this your duration is going to be 24 hours, let's say you arrive and the patient's blood glucose level is 300. What would be your goal? The blood glucose level is 300. To reduce the blood glucose level to normal range. And what will be the duration you will be planning to do that?
Within 20 hours, 12 hours.
3 months says within what? You need to give me your answer
Within
and
24
only
hours.
within 24 hours. Yes? What is the duration you are supposed to take this?
I would rather want to reduce my blood sugar level to normal, maybe within 6 hours of the first shift.
She said 6 hours of the first shift. Yes. Jisha, I will meet you. I need you to give me a time period. Within 6 hours, yes. Marianne.
Within 4 hours.
It should be within 4 hours.
Yes.
You are controlling somebody's blood glucose level. You can't control the blood glucose level for 24 hours. So calm down. No, if you eat, how long does it take for digestion to take place? 3 to 4 hours. And within 3 to 4 hours, digestion should have taken place. That means that by that time, your blood glucose level is either high or your blood glucose level is low, right? So if you want to take a medication, you are on insulin sliding scale, do you need up to 24 hours to get that blood glucose level to normal? Within 24 hours, how many times must you have administered the medication?
2 times.
Exactly. So why will you be administering the medication 2 times already when you have not gotten the achievable or the desirable rate of the glucose level when you want it? Let's say you arrived and the patient was having pain, severe pain of 10 on 10, all right? And you want to reduce, what would be your goal for this patient?
To alleviate pain.
To alleviate the patient's pain. And if you want to alleviate this patient's pain, how long do you need?
30 minutes. 10 to 15 minutes
10 to 15 minutes
for an injection.
for injection. Let's say you would not have injection because you will not be having injection for the patient's one. Your patient is taking oral, or the patient is taking topical, or the patient is taking anal. What would be your estimated time for this alleviation of pain?
1 hour.
1 hour. So this is how you are planning. You are taking the problem that you have. Either it is a problem, or it is an intervention, or it is a promotive intervention you want to do to the patient. You come and you are looking at the goals, and when you finish at the goals, because now you are looking at the directive which you want to go to, you will now go to the duration. If it is pain, you should be looking at 1 hour, 2 hours max. The patient should be relieved already from pain. And if you are not looking at pain in that manner, or you are not looking at the relieving of pain within these 2 hours or within these 3 hours, maybe it's something that is going to be continuous. At least that patient should be comfortable, even though being in pain. And this should not equally take forever. Do you now understand? Because you see most of you writing interventions, but you have no problem. You have no goal. You have no duration. That is because you did not realize the purpose of you taking care of a patient is not simply about treating a disease condition. It is not just about you managing a disease condition. It's about you promoting the patient's health. It's about you preventing a fall and injury, preventing a pressure source. It's about you preventing the occurrence or the worsening the situation. Because if the patient is diabetic and you get the patient maybe sweets when you did not need, how did you have that patient? You have gotten the situation worse. So you need to prevent. It's about looking at the patient who really wants to lose weight and make sure that they eat what they need it. It's about you seeing a patient that is depressed and you start trying to drive this patient into a healthy understanding of the fact that life is still beautiful, even though we have all the problems on earth. So I don't want you to come and I will be seeing interventions. However, I'm not seeing the problem. Neither am I seeing the goal. Neither am I seeing the duration. Because if somebody is telling me here that the duration or whatever they were trying to do, which I cannot read because her handwriting is very small, she says 1 week. What were you trying to solve within 1 week? I hope you understand. You should be able to know the differences between your long-term goal and a short-term goal. And you should be on your daily duties trying to do small works that will save a lifetime. Because this long-term goal that you written here within 1 week, if I ask you 3 days after, you will not be able to tell me what you did here. But if I am able to clarify you and tell you what happened within those days, or what happened today, you'll be able to tell me that. Now, we have the interventions. What did you do? The patient has pain, and I'm trying to use non-pharmacological method to reduce the patient's pain or to alleviate the patient from pain. The patient has been sleeping on a supine position for long. I made the patient sleep upright. I made the patient sleep lateral. And this has helped the patient at least from a pressure ulcer, from an irritation. The patient has been having a lot of back pain, and I did some massage, some very good deep tissue massage, and the patient slept. The patient has been having pain because the patient has been on bed for as long as possible, and I came that day and I decided to take the patient for a walk. With support, we did a little bit of ambulation around the compound. When the patient came in, the patient was exhausted. She took her bath, she was refreshing, and she slept like a baby. I cannot take my goals or my duration and put it for 1 week. My intervention should be actively what I have done for that day, for that patient. Now, you'll see here that there is something that is not included, that is planning. You are not going to plan on what you will do. Rather, you are going to tell us the duration of time in which you want to do what you have to do, and then tell us what you did. Now you go to the disciplinary responsibility. Now, what were the disciplinary responsibilities that you had to take? I wanted to take the patient out, and the patient refused. Because she does not want to go out, she's scared. I called the care partner or the decision maker, and we spoke to Mama, and we took Mama out. This is a responsibility that you have done that day. Does it make any sense? Because all of you, nobody is writing anything on the discipline responsibility.
I have a question on this. The discipline responsible, is it not maybe physician, nurse, or physiotherapist? Because there's that other form of the interdisciplinary who are visiting the home.
Yes, the disciplinary responsibility, that is why I started by saying the care partner. Because not everything is going to be me, or the physician, or the HMC nurse. Some will be you. Does it make any sense? Now, we are talking about who did what, who came to intervene at that thing that you are trying to do. If nobody had come actually to intervene for that, who did it? You did it. If it was something that needed you to have to beg somebody to intervene for that situation to be carried on, then the person becomes the disciplinary responsible for what happened. I could not get the patient to go out, or I could not get the patient to eat vegetable because she does not see any importance in eating vegetables. So I had to call the husband. The husband came, she spoke with her, and she accepted to eat it. The husband is responsible for what happened. Do you understand? It does not mean that it has to be the people from PNS. These are all the people that are responsible in making sure that your patient your patient is recovering in a manner that pleases you and pleases them and pleases PNS and pleases all of us. Because if she is not progressing, she is going to, okay, let's say that she is depressed. If she's not progressing, who do you think will be the first person to start being assaulted? You. Okay, now the outcomes met or not met. Now, if you tell me that within 1 week, I am expecting you to go the day that makes 1 week and tell me it was met, do you think you're going to do this? Of course, you're not going to do it. So I need the short-term goals. Because on this form, you indicate was the goal for that day met? You said yes, it was met. If it is not met, you said no, it was not met. And then you sign. Do we understand each other?
Yes.
Now you have indicated on the 29th of March 2023, and then you said the goal met. The outcome was it met. You are writing out the day that you think should meet. How can can you speak for that day when you yourself did not attend that day? You are not even seeing it. So you are signing on a day that has not come, which you are not even sure you are going to cross-check. Does it make sense now? Okay. If that is said and done, and if you are with complete understanding, then we move forward. I can equally see that the home literacy was done. At least everyone was struggling to do theirs, except somebody did not do. The person can as well indicate to me. I see here you indicate here alcoholism, you said addiction. The individual was addicted to alcohol.
No, this one, we ask the
Ask
caregivers
caregiver, like,
to relate these key distractors to the main one in the first one.
yeah,
Yes.
what you
So-
think first, if you think alcohol,
Is related
it's
to addiction or
it's
recreation.
related or
Okay.
addiction or recreation.
I get you, I get you. All right, okay. Now it all makes sense. Okay, so this home literacy tool is what you use to educate the family or the care partner?
Yes.
Okay. Here we have family education, yes. So how many of these will you be needing for per month? Because certainly it's not necessarily do it every day.
You can do it maybe weekly, so you can do 4 per month.
For per month, so you still need just this one.
Depending on who they are teaching, you can give,
Okay,
because maybe you can be teaching the family or the care partner.
so we have patient and family. Okay, I said there is one patient, I'll give 3, so 1 plus 2 extra.
Yeah.
So who was your care partner? Sorry? Catherine. Catherine was your care partner. And that is where I said the care partner must not be the decision maker. There are times you're going to have a care partner that is the decision maker, and there are other times that you're going to have a care partner that is not the decision maker of the home. So here, Catherine is going to stand to be a care partner. However, she's not going to be the decision maker of that. And you will see other homes where the care partner is one of the daughters or the son and is the decision maker of that patient. Does that make sense? Okay. This is still going to be 1. So when you finish the documents per month, the documents like the care partner, the initial assessment forms that you will not need to use or change, you will not send it back because you still need it in your file, okay? You will send back only the documents that you will need them to be refilled every month or every time. Is that okay? So you will send it at the end of the month, you select only those that will need you to be refilling or reusing, that I should send new ones. If not, you will ask the driver to bring it to me, and I will send your new shape files to him. So when you want to send him, you will send me a list of the files that you need for that month, and I will prepare them, and we will simply do an exchange with the driver. The driver will give me the ones you send, and I'll give them the one you have equally sent, and they will take it back to you. Is that okay? Except I'm coming for supervision in your area, then you can ask me to bring the files that you need to you. Is that okay? Because probably when you start working, I will not be seeing you except on phone. So do not be surprised that we might be here and we are all in Doha and we are all working on the same position, and I will see you once a month when I am coming for supervision. Apart from that, we will never meet. Or maybe once per every 3 months, depending on how many nurses I have to supervise for that month. Because I can only supervise 25% of the total nursing population per month. So there are people that will see me only once after 3 months. Okay, so we go to our initial assessment form. Initial assessment form. As well as the initial assessment form is one you are going to keep in your folder. Is that okay? Okay, they say I have the last number 9, page number 9 says other preferences, spiritual beliefs, cultural norms, healing modalities, and recreational therapy. Of course, we might not have the other beliefs. That is going to be all your patients will be Arabic and they have the same belief Muslims. And the differences you're going to be having is recreational therapy. You need to ask your patient if they have any kind of recreational activities that they want you to take consideration of. If it's a Gen Z patient, she should surely have a program that she's following. Maybe it's a Princess Tyra, or maybe it's one of the what do they call it? Cinderella movies that she's watching on Netflix, and probably it has a specific time that that movie is going to. If it is a series, you don't want her to miss it, because if she miss it, you are going to miss your piece. Okay, so you let her know, or you ask so that she can tell you if there is one thing that she really wants to do, and if it has a particular time. If there are people that are doing their slim course, or there are people that are getting lifestyle changes, you are going to see that probably she has a detox tea that she takes in the morning, or a detox tea that he takes in the morning, and then you cannot get that away. Or maybe he drinks hot water in the morning. This is some kind of recreational therapy for his brain. You should be able to make that arrangement and make sure that every morning you should give them what will make or kickstart their day. Is that okay? If someone that loves sports and has a particular sport they like to do at home, they will tell you, and they will tell you the time they like to do their exercises. Some might want to do their exercises in the morning, and some might want to do their exercises in the evening. You should be available to make that dream come true for them. Okay. So I can see here the question was never asked because it was never filled. You can't tell me otherwise. You can't tell me you asked, but you know that.
I have a question on that now.
Yes, ma'am.
If, like, for example, the patient is not verbal,
Yes.
she cannot verbalize, do we get the information from the care partner?
You can
the
ask-
decision maker?
You can ask the care partner as well as you can ask the decision maker. Okay? The decision maker tells you that when mom was still active and verbal, she had this culture of doing this particular thing, do it. It's going to boost their unconscious mind very much. It's just like when your patient is in coma, we always advise that one of the family members with whom that patient had a very good bond should keep talking to the patient, because they will unconsciously bring back the patient to their conscious state just by sending their voice into the patient. Is that understood? So yes, you can ask the questions and you get the answer and you try to do it. Okay, discharge plan. We have here assessment completed by, there was never any name, I'm not sure any of you wrote. You wrote? It was completed by your name, okay? Prima, you wrote? All right, Jisha, you wrote? Okay. For Mary Ann, she did not write it. Page number 10. Did you write it? No, even on that one, you still did not write it. Exactly. Now, most often, it will always be completed by me and you. Okay? Because we are always going to do our initial assessment together at all on.
But I have a question. That's why I don't write, because it's confusing.
What is confession?
LNM, discharge planning and discharge summary. What is this two?
Discharge planning. You have the discharge planning, which is there. Okay? Now, PNS is giving us a patient within 3 months. And after 3 months, we have to apply again for continuation of care. And after 3 months, we have to apply again for continuation of care. If the patient had just a fracture and was out of surgery, then within 3 months, that patient should be good. Okay? And then you plan for their discharge. Now, discharge planning, let's say that the patient was having a fracture and you went home with the patient. Okay? And after, say, 2 months, the patient is well. 3 months, the patient starts using walker. What is your plan? You will maybe have to put the patient on, the patient is having physiotherapy that they are following, the patient is having some food regimen for a dietitian that they are following, the patient has some medications that they have to be taking, okay? Now you're going to write the discharge plan. Has to go for physiotherapy 2 times a day or 2 times a week, I beg your pardon, or maybe 2 times per 2 weeks. That is once a week, once a week. Does it make any sense to you?
Yeah, but I mean the assessment, the one that we make, because it's under discharge plan and discharge summary.
Your assessment completed by, it is on its own. They have given you space for planning. You did not plan. So now, can you finish your assessment alone?
This
Do you
discharge
understand?
planning is part of the
It's
assessment.
just like you having from one point, you go to the next point. Do you now understand? Okay. So now discharge summary. Now with the discharge summary is you saying everything. Care completed. The individual had a fracture. We save our services within 3 months, and the patient is fine, and the patient is ready to be independent. Remember, you are only taking care of a patient because the patient is lacking 1, 2, or 3 of the fundamentals of regional medicine. If they have, or if they respect all the fundamentals, why would they need a patient? Why would they need a nurse? They will not need a nurse. If they are, even if they have surgery and the next 2, 3 days they are on their feet and they can move, and they can respect all their 14 fundamentals, you will still not be needed. So for the care summary, you indicate care completed. The patient is fine. The patient can eat, they can breathe normally, they can recreate, they can choose their dresses, they can bathe, they can dress the way they want, they can ambulate if they want to, they can eliminate body waste without any necessarily needing catheter or diapers. They don't have any broken wound, the wound is healing. If it is a surgery, the surgery should be finished, it's a sterile wound. It should be finished for first intentions, and that is within 5 to 7 days. Mary Ann,
Yes.
are you with me?
Yes, ma'am.
So you give the summary. Now, if there is if you want the summary, the discharge reason, if you want a caregiver to be trained, then you indicate if there is a presence of the caregiver and caregiver's training is completed. That means you are now handing over your services to the next person. It's like an endorsement. Habibi, do you understand?
Yes. Yes, ma'am. I understand.
I have a question.
Yes, come on.
Like you've said, we are taking 3 months contract. For example, like that sterile wound.
Mhm.
After 1 month, the wound has healed and there is no need, so you start planning for discharge. Do we discharge the first month, or we'll have to wait for the 3 months?
You wait for the 3 months. Okay? Now, the wound must have finished within the first month, but you still need to assist the patient in getting confident and in gaining movement. They will not be able to respect their posture or move correctly, right? They will still be risk for falls. So they will still need your support. And that is where you start taking them for physiotherapy, nutrition, to make sure that they eat enough proteins to replenish the dead cells or to help in boosting growth of new cells. Okay? And within the 3 months, the patient must have recuperated completely. The patient must have been using maybe just 1 crutches to walk, not 2, or not a wheelchair. And they'll be able to walk by themselves around the house and do their duty. They'll be able to bathe. There will be no catheterization on them and nothing. So you just wait for the 3 months, and the services for that first 3 months is over. We give a discharge plan, they sign their discharge form, and voila, service finished. But if there is a need to continue, because even though they'll be giving you a patient that has just come out from a theater, they might feel like within 3 months it's over. But then within that 3 months, the patient now has an infection. The wound is not finished. You still need to be there. So we will have to indicate the reasons for which we want this duty to continue, and they'll give us another 3 months to get a new goal. Any question? We have discharge instructions. The discharge instructions is what you will tell to your care partner, or what you tell to the family, or what you tell to the patient when you are discharging them. Remember, you were the one with their care, you were the one with their medications, you were the one giving them the food they are going to eat, you were the one doing the physiotherapy, the massage, the exercises. Now you are going, you need to tell them what to do. As you are caring for your patient, you are caring for your patient in promoting them into their independence, so that they don't depend on you. And at that time, you should have promoted them in a level where they understand exactly where their medications are, how they are supposed to take it, what time is what, and which medication is supposed to be administered. If they are having high blood glucose level, what they are supposed to do. There are patients that take their own shots because they have been trained. They have been trained into their independence. Is that okay? We are nurses, not that we are praying that patients should get sick. We are nurses, and we are hoping that if any patient gets sick, they should be able to get a good nurse or a good doctor or a good health personnel that will care for them and gain and win them back into their independence. Nobody wants to be dependent on an outsider coming to see their products. All right, we are having social determinants of health accessibility. Is there anybody that did not answer something there?
Just the parts that like the patient's responses. Like how are you coping with your illness? Are you feeling down, depressed, and hopeless? Because some of the patients are not verbalizing, yeah, just that. But the others were easy to feel.
Yeah, I think for those that you are going to feel if the patient is completely cannot verbalize, you certainly should know what to do. It's like knowing, of course, if the person cannot speak.
But we can also feel with the decision maker because
yes, you can feel with the decision maker. They have been there.
Yeah.
Here they said, in the past years, have you used any unprescribed medication? If yes, how many times? Once daily, twice daily, monthly, almost every day. You have no answer. If it is a no, say no. Don't just keep the space line. You should fill every gap. Are you feeling down, depressed, hopeless? If yes, how do you cope with it? How do you cope with this feeling? Or cope up with this feeling? Yes, just like you said, some of the family members might not be able to speak, but you should ask the care partner. If the care partner has been there long enough, then they are experiencing firsthand what is going on in that patient's life. You don't just take care of your patients, right? You take care of your patient and their family. If not, you might add to the number of patients you already have. We have disabilities. You do not answer any of the questions for disabilities. Because of physical, mental, or emotional conditions, do you have any serious difficulties concentrating, remembering, or making decisions? 5 years old or older. You did not say yes or you did not say no. If the patient is unable to speak, if the patient is bedridden, of course, they cannot make any decision. So you don't need to go to a native doctor to get that answer. Okay? If they cannot be able, if an individual is old and the individual is bedridden, unconscious, or whatsoever, they are just as good as the babies, as children below 5. And if they are as good as children below 5, then they are unable to take any decision. Number 2 says, because of physical, mental, or emotional condition, do you have difficulties doing errands alone, such as visiting a doctor? Of course, they have difficulties visiting or doing any of those, and which is a yes. And Mary Ann, you did not feel that. Even your name is not visible. Even your own name.
Yes, I remember. Even my signature.
Even your signature.
Yes. Even from the minister before they asked me my name, but I can't remember.
Yes.
That's why they have I need them.
Okay. The last one, we have 4 weeks assessment. Let's talk about the 4 weeks assessment. Jisha? Great. Anyone had any difficulties with getting this 4 weeks assessment? Any question concerning it? Mary Ann, when you write your date, when you sign, remember to write your date and time.
Assess one patient for each 4 elements. Yes. First one, information may be gathering from certain documentation. Assessment, the patient or caregiver beyond protocols listed below. Scoring should be based on your clinical judgment. First one is age 65 plus.
It's okay, don't worry, just allow the phone side. I want to go to 4 risk interventions. We have 4 risk interventions. Outcomes of the initial 4 weeks assessment shall be discussed in the initial interdisciplinary team conference. Medication review references or refer to team conference, family conference, learning needs identified, visual impairment, never moved alone. Now, all the 4 weeks assessment that is here, I did not see you answer even one. Even one, you did not answer. Okay. Now, what happens if this patient happens to fall? Okay, and now they tell you to give your 4 weeks assessment form so that they can see what you did assess from the very get-go. And I can't see anything. What do you think will happen to you? You will be termed negligent, and negligent is punishable by law. Because if you did not assess, nothing. Who did? Who assessed their patient?
I have it.
So why did you not send me a form? Why did you not do for this patient? Attend to the patient at all times. Take assistance from caregiver or family. Can your patient move alone?
No.
So why did you not indicate that the patient cannot move alone? You have to be with the patient at all times.
I think the one that she needs assistance from.
Take assistance from caregiver or family. Yes, you'll be taking assistance from caregiver or family. That is because the patient cannot move alone. So
I
you
also
need,
take that.
you need to take the fact that the patient cannot move alone and you need assistance. Now, who has a wheelchair, what happened? Which patient of yours had a wheelchair? Yeah, you had a wheelchair, that means there was availability of a common chair beside the patient's bed. Is that correct? But you did not indicate here.
I think because it was the first patient, I did not have
A wheelchair.
I thought we were just picking the most relevant that you're using to the patient.
No,
But
you
now
take,
I understand that you're taking
you take
everything.
everything that you already know that is for the patient. Of course, you might not be taking the patient every day out, but you certainly will take the patient at some point out. And does the patient has this? Remember, you are checking these things, and what is not available, you ask that they should make available for you. Okay? If the patient has a wheelchair, the patient has a wheelchair. The wheelchair is not small money, it's much money. You make sure that the wheelchair is used safely. Of course, if you don't lock a wheelchair and she happens to want to push and make, or somebody push from behind, the person is going to fall. You have to make sure of that. For somebody that was going to, that is urinating but not urinating using a urinary catheter, however, they are using a bedpan, of course, this is where you keep the urinary can within reach of the patient. That means the patient can be able to take care for themselves at some point in time. Okay? If it does not imply or it does not apply for your patient, you let that one go. Attend to the patient at all times. Keep the patient's bed neat. Keep the patient's bed near the bathroom as possible. For the patients that can go out, and yes, and you will check if your patient's bed room is closer to a washroom. It shouldn't be far because if you have to carry the patient, if you have to assist the patient, you don't want to assist the patient for a very long distance. Your patient had nothing to do with pain.
When it's 3 p.m. because Naga is asking.
If it's 3 p.m. it's okay, we can call it because we are done after. 3 p.m. is 2:24 with me.
I mean, what time we will finish?
Okay, he's asking what time
Yeah,
we can come. Tell him to start coming.
he can come.
Yes, with the documentation. Which other documentation do you need clarification on?